Hi, my name is Susan Elliott, and I'm a nurse practitioner at St. Lucie University. I work in the Division of Geriatric Medicine, and the talk today is on nursing and post-acute long-term care. Excellent nurses needed. A disclosure, my university does receive funding through HRSA via a GWEP grant, which is a Geriatric Workforce Enhancement Program grant, and part of my salary is supplemented. What is the post-acute long-term care environment? Well, it's community-based. It's very diverse, whether or not it's the people working there or the people that we're caring for. It's usually 8-hour shifts versus the 12-hour shifts. You get to learn acute and chronic skill sets. There's a career ladder and lots of leadership potential. So a lot of places will say they have team-based nursing, but in post-acute long-term care, we really do. You'll see here at the bottom, there's 63.9% of the employees that work in post-acute long-term care are the aides, which are the CNAs and the CMTs added together. In the middle, we'll find our LPNs make up, 1 in 5, a little bit more than, of the workforce, and then RNs are at 11.9%. So the closest you are to the base of this, the higher potential you have to actually improve facility quality, but also climb the career ladder. And it may be less daunting to climb the career ladder in post-acute long-term care than in acute facilities. When we look at what the recommended staffing levels are by type and acuity, and this is before the pandemic, RNs should have been spending 1 to 9 ratio up to 28 patients, and LPN should be seeing 1 to 14 up to 38, and aides should be seeing 1 to 5 up to 7 residents. When you equate that over into hours per resident day, the recommended time for RNs is 45 minutes up to 2 hours and 18 minutes. LPN, a minimum of 33 minutes up to 1 hour and 41. Aides should be spending 2 hours and 48 minutes up to 3 hours and 36 minutes. So the total staff hours really should be somewhere around 4 hours and 6 minutes up to 7 hours and 40 minutes. One of the facilities that I work in, a very good facility with a high star rating, I looked up the numbers and this is what's listed. It's hours per resident day, and then in parentheses you'll see the national and then the Missouri average. So the RNs were spending 22 minutes, so less than half of what the required time is. LPNs were at 46 minutes and aides were at 2 hours and 6 minutes for a total staff of 3 hours and 14 minutes. Keep in mind this is an excellent facility, so you have to wonder where everybody else is. The pandemic really has hit everyone hard. So the post-acute long-term care staffing shortages before the pandemic, when we looked at the levels from 2017 to 2018, 80% were understaffed and 3 out of 4 were never compliant. So staffing is a component of the 5-star rating system by CMS, and so it's no surprise when we look at facilities that have low star ratings that you would have a high staff turnover. In fact, 135% turnover in a 1-star facility. It did surprise me, however, though, that a 5-star facility, which is the highest you can get, still had a 76.67% turnover rate. So really, you have to understand how it works. So Medicare residents and hospitals actually choose the higher rated facilities. And then the non-Medicare residents, which usually have a higher acuity, they're harder to take care of, go to the lower star facilities. They get less reimbursement, more work to do, so it creates more burnout and turnover, which leads to staff leaving, more agency use, and a lower star facility rating after that. So it's a vicious cycle. The staff shortages worsened with COVID. 99% of the nursing homes said that they had staff shortages in a 2021 workforce survey. 69% found it very difficult to hire and now needing agency staff. 99% were depending on overtime. There was low candidate interest. In fact, being afraid of COVID-19 was a relatively small reason why people didn't come. Burnout and turnover was bad, and these numbers are from 2016 to 2019. So pre-pandemic, the RN turnover rate is 140%, LPNs 114%, and CNAs 129%. In fact, burned out or dissatisfied RNs were 5 times and 2.6 times respectively more likely not to perform needed care for residents. When we had LPN turnover, it was significantly associated with infection control techs. So agency staff. Agency is a big problem. I would consider it almost the biggest problem in post-acute long-term care. They don't know the residents. They can't detect changes in status. They can't communicate with the families. They don't understand the EHR or the facility protocols, and they don't want to learn a lot of the time because they'll be off to their next assignment. I have a lot of experience working with agency staff, and some of them are excellent, but there's a lot of people that just move on to the next location. In 2009, before the pandemic, it was identified that facilities that used 25% or more agency staff had significantly decreased quality measures. In fact, homes that didn't use agency staff had better measures on 11 out of 15 compared to those with 25% or more. So CMS has tried to address this. In 2022, they worked to develop a template to help states tie the Medicaid funding to staff wages and benefits, and trying to increase the wages for experienced clinical staff and specialized staff and provide career growth opportunities. So it's wonderful these actions, interventions have been put into place, but so far we haven't realized any benefit from this yet. More to come. Staff retention. Really, we need to be focused on person-centered culture with inclusion, respect, appreciation, education, and including everyone on the interdisciplinary team. We need to increase the number of permanent staff, period. It just has to happen. Build on efficacious techniques employed during the COVID-19 epidemic. Some of the facilities that I work in are really trying to be flexible with people with their hours. That seems to be a big draw. And empowering staff through leadership. So it's identified that, CNA retention was a lot higher when we empowered CNAs to be part of the team and have a voice. Looking at salaries, the United States nurse SNF salaries, so skilled nursing facility, you can see here RNs make $34.74 an hour, LPNs $25.80, CNAs $15.43. The post-acute long-term care LPNs were the highest paid in their sector, right? So RNs that were med-surg RNs made more than post-acute long-term care, but when we looked at the LPNs, it's the ones that were in the post-acute long-term care that made the highest dollar amount. And we'll see that concept repeated. The Missouri salaries, no surprise that they're lower than the national average. In fact, among the 14 states most populated, they are in the 12 states with the lowest salary. Now RNs, that was RNs, and then CNAs among the 12 states most populated and the 11 states with the lowest salary. So same thing with the CNAs and the RNs, but look at the LPNs. It's actually the average. So you can see where Missouri puts its priority is on having an LPN. The Missouri nurse salaries are listed here. You'll see the hourly wage on the left and then the mean annual wage on the right. So RNs are at $32.59 per hour, LPNs $22.12, and CNAs $14.9. In St. Louis, a large metro area, things are a little better. RNs are making $33.96, LPNs $23.91, and CNAs $14.78. So CNA staff are the key to resident quality of life. They should be empowered, included in the care planning process. I have to admit that I don't see this much. They're often off doing their jobs while other people are doing the care planning. And they should be integrated into the interdisciplinary team to improve age-friendly care. CNAs should be empowered to improve quality care through education and improve the 4Ms, which is what matters most to a resident: medication, mentation, and mobility. CNA retention efforts should focus on increasing knowledge for self-efficacy. We should have some self-compassion programs for stress management. The evidence supports both of these interventions, and then increasing the perceived social support through understanding the importance of their role and representation on the team. LPNs are the hub of the interdisciplinary team. They provide most clinical care in post-acute long-term care. They have less education than an RN, but they do absolutely all the work. So we need to provide our LPNs, our clinical LPNs in post-acute long-term care, every educational opportunity we can. Skilled nursing. The focus is on regaining function. Managing acute problems. We really are looking at what the percentage is to get that person back to the community. Some of the short stay quality measures you see here, like an independent mobility improvement. Are they having pressure ulcers, new or worsened? How many of them had an antipsychotic for the first time? So these are all quality markers that were scored on and should be the priority of LPNs that are working or RNs on a skilled nursing floor. The acute care nursing skills are all over. So you can practice from low to high acuity. It's an excellent environment to learn your skill set. On the long-term floor, the goal is really preventing decline, promoting quality of life, and managing the acute problems and chronic problems. Albeit acute problems happen along the way, but really the focus is on chronic problems. So we're looking at our long stay quality measures. So how many are needing assistance with their ADLs more, or have a worsened mobility, or maybe worsened pressure ulcer or a new pressure ulcer? Do they have catheters? Have they had falls? What about hospital stays? Are they going out to the hospital more and the emergency room? These are all quality markers that go into the big mix of facilities and how they're ranked with CMS. So nurses that are working on a long-term care floor, whether they're LPN or an RN, are really building a combination of acute and chronic skill sets. The RNs tend to populate the leadership roles. They can mentor the LPNs and the CNAs. They have an opportunity to shape the culture of the facility and implement age-friendly healthcare concepts. They're often the nurse supervisors, nurse manager, the assistant director of nursing, the director of nursing, so and sometimes the administrator. One of the roles that nurses can do in the post-acute long-term care is to be a prevention infection control nurse. And there's actually a certificate that goes along with. CMS in 2022 started requiring at least having a part-time preventionist in the facility. And you can see here they have a lot to do with vaccinations and event reporting and antibiotic stewardship. Another role is a compliance nurse. So really looking at the MDS set that you see here. There's many things that we track in the nursing home to see how people are doing and to rate their care and their goals and whether or not we're achieving their goals. So just staying up on that is a full-time job. In fact, we're probably one of the most highly regulated industries out there. Care quality. BSNs are needed in post-acute long-term care. I've got several people in one of the facilities that I work with that started as a CNA, moved up to LPN, obtained their 2-year RN, and now they're working on their 4-year RN, so a BSN. This is through some of the in-house opportunities to move up the ladder. And if you look at the Future of Nursing report from 2020 to 2030, BSNs improve patient outcomes and are needed. But look at the first bullet point, decrease in mortality in older Medicare patients and hospital readmissions and expenditures. So these are the things that matter. So they decrease the risk of death. They lower the chance of readmitting to the hospital, which is part of one of the quality measures that we just talked about. And they're positioned to mentor people. I've alluded to the career growth several times. A lot of facilities tend to promote from within, which is a wonderful thing. There's on-site certifications now to become a CNA, to become a certified med tech. The certificate, the CDC certificate for being a preventionist or an infection control nurse, being an MDS specialist. There's scholarships and tuition reimbursements. There's one young lady that started as a dietary person that then became a CNA, that then became an LPN. Now she's an RN. So it's really a good opportunity to build your skill set. So the education programs and the partnering with academic institutions like ours, it's a wonderful combination, and it increases quality. It also increases your chance at permanent staff retention too, because people are happy and they're growing. So some of the final thoughts I'd like to leave you with is that the goal really needs to be progression. Wherever you start in the chain, if you're coming in as a CNA or if you're coming in as an LPN or an RN, there's room to grow in post-acute long-term care. And then increasing our retention by having regular staff, valuing everybody on the team and everybody having a voice. It's really a home-like environment. And I hope everybody will find the value in this. Our older adults deserve it. So that's the end of the presentation, and here are some of my references. And if you have any questions, you can reach out to the Gateway Geriatric Education Center. We're happy to share our resources, answer any questions you might have. Thank you.